This will be the first video in the cardiovascular module. In this video, we'll look at the basic anatomy of the cardiovascular system and how it helps to maintain homeostasis. And then we'll look at the structure of blood vessels and the whole arterial and venous and capillary system. So the circulatory system is really a major contributor to homeostasis. In traditional medicines, when the word heart is used, like Chinese medicine, it typically refers not just to the anatomical heart, but the entire cardiovascular system, including the arteries and veins and the capillaries and what's called the microcirculation, which I'll talk about here in just a moment. The system really is closed for red blood cells only and platelets and large proteins. So basically, red cells, platelets, large proteins stay inside the blood, but the majority of the plasma, white blood cells, many of them, and so forth, can leak out in the capillary beds. Neutrophils can actually move their way through endothelium and capillaries, but a lot of the plasma ends up leaking out. So it's really not necessarily a closed system, and we'll see that tissue metabolism in the capillary beds is a major factor that actually drives blood back to the heart. So there's some interesting research looking at how the heart is not the sole contributor to circulation. It has also to do with the metabolism in the peripheral beds. We can think of the heart as the head of the circulatory system, the capillary beds as the limbs, the other pole, and then the veins and arteries kind of as the middle mediating element. We might call that the rhythmic element. If you were to stack together all of your blood vessels, including the capillaries in the body, there's well over 60,000 miles of blood vessels. Pretty amazing number. Um, so when we look at the forces that are involved in circulating the blood throughout the body, that is known as hemodynamics. So we'll be studying some of that here. There's two types of circulation. We can think of a mini circulation going to the lungs. We call that the pulmonary circulation. And that's composed of the right side of the heart that receives venous blood from the body. It sends it through the pulmonary arteries. It's the only artery in the body that carries deoxygenated or venous blood. And then that blood goes to the lung capillaries. As we saw in the respiratory block, that's where it interacts with oxygen. Carbon dioxide is exchanged as well. And then the blood leaves the lungs via the pulmonary veins, which carry, in this case, oxygenated blood. So that's pulmonary circulation. We can think of that as a low pressure circulation. And so it's at a much lower blood pressure than the rest of the circulatory system. That pressure can rise, though, causing something called pulmonary arterial hypertension. And pulmonary hypertension can put more stress on the right side of the heart, potentially causing right-sided heart enlargement. Systemic circulation would be the left side of the heart, and it's the left ventricle really, which is the primary driver of circulation. So although both ventricles are important for moving the blood, the left ventricle in particular, the diagram here to the right in the red, that left ventricle is really a massive muscle, and it's what's going to pressurize the blood as it comes back to the heart and put it into the aorta, which then goes through systemic circulation. That eventually that blood makes its way to the capillary beds. Plasma, nutrients, waste products, etc., exchange back and forth, and then that blood goes into little venules, little veins, and then it collects back into the major veins. And then in the body, the majority of the blood from the lower part of the body collects in what's called the inferior vena cava, and then the blood from the upper body collects in the superior vena cava, and that all drains back to the right atrium, right side of the heart. Then we have the right ventricle, etc. So that is systemic circulation. That's under higher pressure, especially the arterial side. And so we'll talk about how we measure blood pressure and what those numbers mean. But that's at a much higher pressure than the pulmonary circulation. So we can think of the circulatory and the cardiovascular system as a threefold system, with the heart as the head of the system. And just like any head, a nervous system, it has a sensory role. So as we'll see, the heart actually is a sensory organ. It's going to help integrate a lot of different factors. For example, the volume of blood, different pressure in the blood and so forth. The heart actually will release hormones and help to regulate the whole cardiovascular tree, just like the brain does for the rest of the body. At the opposite end are the capillaries and what's called the microcirculation. So that's as the blood makes its way into these very tiny capillary beds. where again nutrients are exchanged to tissues and waste products are brought back into the blood. That would be the capillary microcirculation. As we'll see, capillaries are primarily just a single cell layer thick. And those cells, in fact, the cells that line the entire cardiovascular system, which are extremely important, are known as endothelium. So it's the endothelium which keeps your blood flowing and so forth. And we'll look at endothelium in depth here in just a little bit. Then we have veins that bring the oxygenated high pressure blood, the high pressure system. You can think of that as the arterial system, and the veins carry more of a low pressure system, the deoxygenated blood back to the heart. If we look at the structure of arteries and veins, we see that the arteries have a lot more muscle in them, and that allows them to actually vasodilate or vasoconstrict a lot more than veins. So we'll look at that here in a moment. Remember that blood itself really is composed of two things. We need to make sure we're clear on this before we move forward. And that is that we have cells, the so-called formed elements, which comprise about 45 up to maybe up to 50% of the blood. And most of those, up to 99%, are red cells, the erythrocytes. About 1 to 2% are the white cells, leukocytes, and that would be composed of the granulocytes, which would be things like neutrophils, eosinophils, and basophils. And then agranulocytes would be your T and B cells, your lymphocytes, together with monocytes. And then we have platelets that are involved in blood clotting. Platelets have a lot of other roles we'll look at, including helping to send nutrition throughout the body, especially for different growth factors and whatnot for tissues. That's why there are therapies like the platelet-rich plasma, where a patient's plasma or blood is removed, the platelets are concentrated, and then re-injected into a joint space or somewhere else to try to induce healing. And that's because platelets have all of these very profound growth factors within them. So that's the formed elements, but the majority of blood is plasma, which 90% of that is water. And then the other 10% consists of proteins, and that our major plasma protein would be albumin. These are all actually, with the exception of the immunoglobulins, all synthesized in the liver. So albumin is a major liver protein, and it is going to help maintain the plasma osmotic pressure. And that's going to allow the blood to effectively move from the tissue spaces back into the venous and the cardiovascular spaces. So we'll look at those forces that drive that, but albumin is an extremely important part of that. And then fibrinogens, which are involved in blood clotting. There's a lot of other different clotting proteins as well that the liver synthesizes, that when there's a trauma, when certain factors are initiated, that will start the whole what's called clotting cascade to activate, and that will end in an insoluble protein being deposited called fibrin. That comes from fibrinogen. So fibrinogen is converted to fibrin, and fibrin will help keep the whole clot stabilized as it forms. Then there are the immunoglobulins, which of course are produced by the immune system, but they're found in the plasma as well. Then we have electrolytes, things like sodium, potassium, calcium, and so forth, phosphate, bicarbonate. We have metabolic nutrients, so things like glucose, fatty acids, amino acids. Metabolic waste products, a lot of them would be things like carbon dioxide, but also urea, which remember is what the liver does to essentially dispose of the ammonia within amino acid groups. It's going to make urea out of it, together with also uric acid, which is the waste product of the RNA and DNA breakdown. So urea, uric acid, a lot of other different nitrogenous wastes and different things that the liver has processed will be in the blood as well. Much of that makes its way to the kidneys and will be excreted there. And then importantly, there are hormones, and these hormones are found in very tiny concentrations, really what we might call homeopathic concentrations. So 10 to the minus ninth, to 10 to the minus 12th often. These are nanograms or picograms, which in the homeopathic language would be 9x or 12x dilutions. These hormones are going to be secreted by all the different endocrine glands, and they're going to essentially communicate through the blood instructions for how to maintain metabolism. The other system that's at work there, of course, is the nervous system. So we can talk about the neuroendocrine system really as your primary coordinating system in the body. The nerves, of course, are outside the blood vessels. The metabolism really is going to be more connected to the blood system. So we can think of the two poles of the neuroendocrine system as being nerve and blood. So this is the blood composition. So when we say blood, we have to really refer to what aspect of the blood we're talking about. Before we move on, I just want to say a couple of words again about capillaries. Again, we can think of them as a single layer of single cells, the so-called endothelial cells, and they rest on a basement membrane of proteins. So there's different proteins, glycoproteins, and whatnot that the endothelium sits on. And the endothelium has, usually it's tightly bound. We'll see there's different types, three basic types of endothelium, depending on how leaky it is to the plasma. But for the most part, erythrocytes, platelets, and large proteins like albumin will not be able to pass through this membrane. So we say this membrane is impermeable to those, but it's completely permeable or semi-permeable to other things like water and electrolytes and so forth can pass through that. So that's going to be an important aspect of what maintains the capillary hemodynamics. In this picture, you can see the erythrocytes, red cells. Really, most capillaries are so small that a single erythrocyte can only fit through at a time. In fact, some of them are smaller than the erythrocytes. So the erythrocyte will actually have to do things like secrete a gas called nitric oxide, NO, which will actually help the endothelium relax a little bit, and that will allow it to squeeze through. A lot of cardiovascular disease we're realizing is related to the health of these endothelial cells. When they're not able to properly relax, when they secrete pro-inflammatory factors or other things, they can actually start the process of having platelets stick together within the blood and so forth. In fact, we'll see one of the major triggers for getting platelets activated, and that's when we say activated, they actually change shape. They start to look like little blobs, and they actually start to stick together. That's called platelet activation, and that'll be the first part of the clotting process. That process is often happens because of damage to the endothelium, and then the underlying basement membrane is exposed to the blood. Normally, the blood should never be in contact with the basement membrane. But if we have endothelial cell damage, we'll have that, and that will lead to the whole process of clotting inside the blood vessels, and that process is known as thrombosis. And we're realizing a lot of cardiovascular disease is related to thrombosis. So blood vessels transport blood throughout the body, and again, that consists of the plasma and the cells. They deliver blood to nearly all tissues except what are called avascular tissues, and that would be cartilage, the epithelium in the skin, so skin epithelium, or really any epithelial layer. So technically the endothelium is a type of epithelium, but also, for example, in the gut lining, all those cells are epithelium. In your respiratory tract, that's epithelium. Epithelium is unique in that all those tissues have a basement membrane, and they're avascular. So there's no capillaries that actually go directly to the epithelium. So the epithelial tissues get their nutrition from the layers underneath them, which are vascular. The lens and the cornea of the eye are other examples of that. When we look at the different types of blood vessels, we have arteries, and there's different types of arteries. Some are more distributing the blood, some are elastic, and they actually help to maintain some of the pressure in the arterial system. So we designate them elastic or distributing arteries. There's very small arteries called arterioles, and then that goes into the capillaries, then the blood collects into venules, veins, going back to the heart. Again, I won't go over the blood, but remember the difference here between plasma and the cells. Arterial blood is blood found in the arteries, rich in oxygen, nutrients, is carried away from the heart. Again, note that the pulmonary artery actually is carrying deoxygenated blood, so it's not carrying arterial blood. Typically, the oxygen saturation is between 95 and 100%. And when that starts dropping, that could be a sign of all sorts of different problems like respiratory illnesses, as we saw, and so forth. So that would have to be looked at. Venous blood is found in the veins, very rich in carbon dioxide and wastes carried to the heart. Again, pulmonary vein is an exception here. It carries oxygenated blood away from the heart. All other veins carry about 75% oxygen. So unlike what a lot of people might think, your venous blood still has oxygen in it, but it's at a much lower threshold, 75%. So there's some reserve there. Even in intense exercise and whatnot, the venous blood still carries hemoglobin there, still has some oxygen bound to it. If we look at the structure of blood vessels, there's really three basic components of all blood vessels, arteries, veins, etc. There is what's called the tunica intima, which is the inner layer. It's the thinnest layer, and it consists of the endothelium, as we said, and a basement membrane that it rests on, and then usually some elastic bands around that, and that's called the internal elastic lamina, and that gives a springiness, stretchiness to the blood vessel. And then there's sometimes thin parallel elastic bands as well. So if we look at the picture over here, they depict an artery and a vein. The tunica intima would be the part here with the endothelium here, as well as the internal elastic lamina there. And then you see the basement membrane as well there. So this is all the tunica intima. Veins are similar, although veins have an additional sort of feature, and that is that the tunica intima has a valve built into it. It's a little fibrous flap, and the valves are really unidirectional. So unlike arteries, which can, as we'll see, they have a lot of smooth muscle in the next layer called the media layer, the tunica media. Arteries can constrict, they can dilate, and that helps to propel blood through them. Veins are pretty much dependent. They have very little smooth muscle, and they're very dependent on the surrounding skeletal muscle and whatnot to pump the blood through. So like the veins in your leg, as you contract your skeletal muscles around them, it pushes blood through the vein, through the valve. Then when the skeletal muscle relaxes, all the blood would just fall right back if it weren't for the valves. In fact, the valves they're one way, so they basically they start to shut as the blood starts to fall back, and that keeps the blood from pooling and going down further back into the vein. In varicose veins, those flaps become too flabby and they become inefficient, so we start to see then blood pooling lower down the vein. We see dilations and so forth of the vein itself. The next layer would be the tunica media, and that is a layer of circular elastic and connective tissue fibers. This is where the smooth muscle is found. So if you look at arteries, they are very rich in the smooth muscle, very thick smooth muscle, and they have a lot of the elastic lamina. So this is the thickest, the media is the thickest layer in the arteries. There's no elastic lamina in the veins, and their smooth muscle is much thinner. So there's a difference there in the media. And then in the tunica adventitia, this is the outside covering of connective tissue. So it's a tough connective tissue layer. It actually contains a little nerve supply, especially in arterioles and larger arteries. Larger vessels even have their own nutrient capillaries. It's called the vasa vasorum. So some of these larger blood vessels have their own little circulatory system to give the tissues nourishment. This is actually, the adventitia is the thickest layer in the veins, so it gives the veins more of a tough outer coating there. In terms of capillaries, again, just a single layer of endothelium with a subendothelium, which is really a basement membrane, plus the connective tissue. And so you can see that in this picture here of a capillary. Here is the endothelium. And again, we'll see there's different types depending on how tightly joined they are. Some endothelium also have pores that allow things to get through them. But that's resting on the basement membrane, which in healthy situations should never be exposed to the blood. So that's the basic structure of your blood vessels, 3 different layers. Now, arteries and veins to some degree can regulate their inner diameter by contraction of the smooth muscle. So that smooth muscle layer really allows to regulate circulation. That's going to change blood flow to downstream organs. So if the arterial dilates or vasodilates, that will allow more blood flow. If it constricts, obviously it's going to cut off blood flow. That will also help to regulate thermoregulation. So as if you get heated, you need to dissipate heat from the core of your body. The blood vessels near the periphery and the skin, all the little arterioles will actually vasodilate, and then blood will come to the surface. You'll look flush, but it'll also help to ventilate heat to the outside. And that will also help regulate how much blood is going into that capillary microcirculation that I spoke about earlier. So what regulates vasoconstriction? This would be, of course, the contraction of the smooth muscle, and that's going to be regulated by vasoconstrictors. And the most common vasoconstrictors in the body would be your sympathetic nervous system. So your arteries and arterioles are highly innervated by the sympathetics, the veins much less so. But the sympathetics really innervate the arterial system. And of course, the major neurotransmitter of the sympathetics is norepinephrine. And then from your adrenal gland, your adrenal medulla, we have epinephrine. So those two are vasoconstrictors. Um, for the most part, it gets complicated because, again, it depends not just on the neurotransmitter, but what receptor it's activating. So remember with norepinephrine and epinephrine, there are two types of receptors. They're known as adrenergic receptors, and that would be the alpha receptors and the beta receptors. Well, it turns out alpha 1 receptors are on a lot of your vasculature, and when that's stimulated by norepinephrine, it causes vasoconstriction. However, some of your skeletal muscle actually has beta 1 receptors, and when norepi binds to beta 1, it actually vasodilates those vessels. So that sounds complicated, but if we think about what the sympathetics are doing, they're essentially trying to increase the activity of your heart and your lungs and your muscle, your major muscle groups, so that you can run away from a danger. It's going to take blood away from organs like your digestive tract and from your smaller muscles like in the hands and the feet and so forth. So that's why you might, under high sympathetic tone, you get cold hands and feet. It actually tends to shut down the circulation in the digestive tract, but it's going to shunt blood to the heart. It might increase heart rate, it might increase the breathing, and so forth. So all of that would be why we see a difference between those two. But for the most part, we think of the sympathetics in many tissues as is vasoconstrictive. Prostaglandins, remember, are mediators of inflammation. Many of them are vasoconstricting as well. And then different hormones. So we'll talk about a very important one here called angiotensin 2. And that's going to be part of what's called the renin angiotensin aldosterone system. Keep that in mind. I'll go through what that is here in a bit. But angiotensin 2 is a peptide hormone, and that is going to help regulate vasoconstriction. So is antidiuretic hormone, also known as vasopressin, which comes from your posterior pituitary. So we'll look at how all of these in a bit, how they integrate, but these would be examples of vasoconstrictors. Vasodilators, on the other hand, would be any agent that's going to relax smooth muscle. Unfortunately, the parasympathetic nervous system, the data so far suggests that it doesn't innervate the blood vessels as much as the sympathetics, and so acetylcholine and all that doesn't seem to be very vasodilating. There are some exceptions in the lungs, for example. There are some effects from, vasoconstriction actually from acetylcholine, but I won't go into that here. But one of our major vasodilators is nitric oxide, as I mentioned. It's a gas, only stays around for a very brief time, seconds really, and but that when it's synthesized, it's actually nitric oxide is synthesized from the amino acid arginine. And that's why some people actually take L-arginine as a nutritional supplement to try to lower blood pressure, because the idea is it'll help to generate more nitric oxide. And there are enzymes, it's called nitric oxide synthase. There's actually 3 of them. I won't go into that, but Endothelium has one called endothelial nitric oxide synthase. And when that enzyme takes L-arginine, it makes nitric oxide from it, and that's going to actually cause the smooth muscle to relax. It also causes the endothelium to be more relaxed, and that's going to allow easier blood flow through the vessel. Okay, so that's the determinants of vasodilation, vasoconstriction there. Now again, the arterial system really is a high pressure system. And so we can think of that as one circuit of the circulatory system. Starts in the left heart, the blood goes out into the aorta, which then branches off into multiple arteries, eventually arterioles, and then capillary beds. Now the arterial system is interesting because anywhere in the arterial system, like the radial artery, if you palpate it, you can feel pressure waves. And so the pressure waves are in sync with the heartbeat. So basically, as the heart ejects blood from the left ventricle, it's going to push blood into the aorta, and that's going to raise the pressure. The resting pressure of the arterial system is the diastolic blood pressure. So when you take a blood pressure like 120/80, the diastolic represents the resting pressure in the arterial system. The rise above the diastolic to the height of the systolic, in this case 120, this 40-point difference actually represents the amount of pressure ejected by the left ventricle. So that's going to be the excess pressure put into that system. As you can imagine, as the blood pressure goes higher, as the diastolic, for example, goes up to 90 or more, the left ventricle has to work that much harder to maintain blood pressure. And over time, as we'll see, one thing that can happen, and it's a very common thing with hypertension, is the left ventricle starts to enlarge. And after a point, that actually leads to the heart beating less effectively. So we'll look at that. That could actually lead to heart failure. So that's the high pressure system. Again, you can feel the pressure waves, and part of that is because the arteries have, again, a lot of that elastic lamina, and so they can stretch, and that pressure wave can be felt all the way down the artery. In fact, as people get more calcifications in the arteries, and this is not uncommon with aging, their arteries actually get stiffer, and especially their arterioles become stiffer with calcium. It's a condition known as arterial sclerosis. We'll look at that in the pathology section. There's another related condition called atherosclerosis, which is formation of plaque in the larger arteries. But arterial sclerosis can make your smaller arterioles stiffer. They don't vasodilate adequately, and that will raise your blood pressure. And so that's why blood pressure typically increases with age, and that's partly a natural phenomenon. But if it accelerates too quickly, that can have all sorts of different changes, like I said, having the left heart beat too strongly and causing left ventricular hypertrophy, enlargement of that left chamber. The venous system is more low pressure and carries the venous blood. Again, that's going to go from your capillaries to venules, veins, into the vena cava, superior and inferior, and then to the right heart. Now this one is interesting because you don't feel pulsations in the venous system. If you look at the blood, it's constantly flowing like sap in a plant. So there's a steady flow. It's not kind of a pulsating flow. And the pressure is constant around 10 millimeters of mercury. So again, a lot lower pressure. We can look at the difference between the systolic and diastolic. We'll look at something called the mean arterial pressure later. It's not exactly the exact difference because the differences between the contraction phase of the heart. So when the heart contracts, that's known as systole. And when we say the heart contracts, we mean specifically the ventricles. We really aren't as focused on the atria in heart contraction. But when the ventricles contract, they contract in unison. So we can think of the heart really as two sort of beating chambers just put together, and they beat in unison. So the left and the right heart contract. When they contract, that's called systole. That's when blood is ejected from the heart. And when the heart relaxes, that's called diastole. So if you look at the pressure difference between systole and diastole in terms of what's ejected into the aorta, you get what's called the mean arterial pressure, or MAP. And that's going to be around, in this case, 40 millimeters of mercury. It's going to be a little bit different because, again, the heart actually spends a little more time in diastole than systole. So it's not exactly the average of the two. But it's around 40 or so, whereas the venous pressure is going to be around 10 in a healthy individual. So we can think of the heart and the lungs really as standing between the high and the low pressure system. Now, there is a concept known as vascular resistance, and this is really where the distal vessels oppose the flow of the blood from the heart. And it's determined by three important factors which we'll need to know about. So one is the viscosity of the blood. So if we have very thick blood, like increased lipids, cholesterol, triglycerides, increased proteins, and that can happen in some conditions like the immune system. It's a cancer of the immune system called multiple myeloma. You start to secrete lots of antibodies, and they fill up the blood, basically making it very thick. That's going to increase the viscosity, so that would increase the vascular resistance, and that would tend to increase blood pressure as well, as we'll see. The length of the blood vessel, obviously, the longer the vessel, the more resistance, and then the vessel radius. So a smaller vessel will have more resistance. So these are the three factors we'll need to look at when we look at different vascular disorders. Now, just as a summary of blood vessel disorders, they can be arterial or venous. So they can affect either the arterial or venous system. So, when we think of the heart, we usually think of heart disease, but we have to always think of the blood vessels as well. And there are a number of vascular diseases independent of the heart. So vasculitis would be inflammation of the vessel wall, and that happens most commonly from autoimmune disease or infection. Hypertension would be high blood pressure. I'm going to be using this abbreviation. So HTN means high blood pressure, hypertension. Arterial sclerosis, as I mentioned earlier, is a hardening or stiffening of the small arterioles, which can happen in hypertension and type 2 diabetes and so forth. DM is diabetes mellitus. This should be atherosclerosis. So atherosclerosis. Atherosclerosis is formation of fatty plaques, or what are called atheromas, in a vessel wall. And this is the leading cause of cardiovascular death and occurs most typically in arteries. And so we'll see, for example, this is our leading theory as to what causes MIs, myocardial infarction or heart attacks, things like angina, and all sorts of what we're referring to as ischemic heart disease. I'll get to that later. Thrombosis is the formation of a blood clot inside a vessel. And if that clot breaks off, it can actually travel downstream the circulatory system, and that is called an embolus. Now, there are a lot of things that can cause emboli. Thrombi are one of them, blood clots. So you can have a gas embolus that happens like in the bends and diving. You can have a fat embolus if someone injects air into your vasculature, that would form an embolus potentially. And the danger of emboli is they can travel downstream, and where the blood vessels get narrower, like in your lungs, in the capillary beds there, the embolus gets stuck, and that can now cut off circulation to a portion of the lung. If it happens in the brain, the same thing can happen. So that's one of the big problems here of thrombi. That's the singular, a plural of a thrombus, which is what causes thrombosis, is that it can embolize. There are also a number of different venous disorders that we'll be looking at. So deep vein thrombosis, DVT, can form down in the veins. And the problem there is the thrombus, again, could break off, embolize, can go to the lungs, forming what's called a pulmonary embolism. And so I'll talk about what some of the signs and symptoms of that are. Varicose veins, and then thrombophlebitis is inflammation in the venous wall, usually due to venous stasis. So these are just a quick summary of some of the different blood vessel disorders we'll be looking at. So I just want to say a few words about arteries here first. Again, these are very muscular compared to veins, lots of smooth muscle. Remember, muscle is not all, there's three types of muscle. There's skeletal, smooth, and cardiac. We're talking about smooth muscle here. Skeletal is your voluntary muscle, and cardiac, we'll see that's the unique muscle of the heart. The two major types of arteries would be elastic arteries. They're also known as conducting arteries. They're the largest in the body, but have relatively thin walls. They have a well-defined internal and external elastic lamina, and then they have a very thick tunica media that has a lot of elastic fibers in it. We call that the elastic lamella. And this would include arteries like the aorta, the pulmonary trunk, together with all the major branches that come off the aorta. These would all be elastic arteries. And they essentially act as what's called a pressure reservoir. So they're able to fill with blood, maintain a certain pressure, and then another pressure wave of blood comes through, and they're able to absorb that pressure and actually store some of that energy in their walls. Then they can contract, and that actually helps to push the blood downstream. So there's a sort of somewhat of a pumping mechanism there based on the pressure. The muscular arteries, also known as distributing arteries, are medium-sized. They have a lot more smooth muscle, fewer elastic fibers than the elastic arteries. So very thick walls of smooth muscle. And they are capable of a lot of vasoconstriction or vasodilation, depending on those vasoconstrictors or dilators we talked about. And this helps to maintain what's called the vascular tone in the body. So here's some of the differences. Here we have a very elastic artery. Here we have a muscular artery. And then here we have an arterial. Notice arterioles have, this a very thick tunica media. They're much, much smaller than in fact, some of them are only a millimeter or two than the regular arteries. But they have a tremendous amount of capacity for vasoconstriction and vasodilation. All right. Another important concept would be the anastomoses. So anastomoses are the fact that most tissues receive blood from more than one artery. And so we have in this picture down here, for example, there is capillary bed here. We see an incoming artery. Many tissues have a little connection that goes straight to the vein. So if this is the normal flow of blood, I'll do it in blue here, coming this way through the capillary bed out to the vein. There's another possibility. And this actually allows, this anastomosis allows for several things. Number one, if there's any sort of blockage in that capillary bed, it won't prevent the blood from going downstream. It also can help regulate how much blood goes into the capillary bed. And if this is, for example, in your liver or your kidneys, it can help to regulate how much blood, how much oxygen, how much metabolic activity occurs in that organ. So this is an alternate route for circulation, usually as a protective mechanism in case blood stops in any one artery. Typically occurs between arteries and veins. It can also occur between arterioles and venules. So that's a little bit on the different types of arteries and anastomoses. Now, again, I mentioned the arterial system is a high pressure system. As blood is ejected from the heart, the compliance, the stretchiness of the arteries allows up to 2/3 of the ejected blood to be stored before it's passed on to the arterioles. So 2/3 of the blood actually goes into the arteries and is kind of storing up there as a reservoir. Only 1/3 at a time actually enters the arterial spaces with each heartbeat. And that retained blood actually builds up pressure, and that allows the blood to be continuously delivered to the arterioles, both during systole and diastole. So it's allows to kind of even out that pressure rhythm to give a constant pressure going into the arterial and the microcirculation. So the arterial pressure then never drops to zero as a result of that. Again, systolic pressure is the maximum arterial pressure reached during peak ventricular ejection of the left ventricle. And then diastolic pressure would be the minimum arterial pressure that occurs just before ventricular ejection during the resting phase of the heart called diastole, as I mentioned. Remember, this phase here is going to be systole. That's the ejection of blood from the heart. So systole and diastole, we can think of the pressures as correlating with those two phases. Arterial blood pressure is usually recorded as both of these, and that averages, like I said, in the average healthy adult to 120/80. When it goes over those limits, we now have different stages of hypertension or high blood pressure. The pulse pressure is the difference between the systolic and diastolic pressures, and it's felt as the pulsations in the arteries of the neck or the wrist. So when you palpate the radial artery, and you feel the heartbeat, that's really the pulse pressure wave. So you're feeling the pressure wave coming down that elastic arterial system. And there are three main determinants of that pulse pressure. So one is what's called stroke volume. Stroke volume is the amount of blood ejected by the heart with each heartbeat. So that is, so if it puts out, a couple of 100 milliliters, that's going to be the stroke volume with each heartbeat. The second factor that determines the pulse pressure will be the speed of ejection of the stroke volume. And the third factor will be what's called arterial compliance, and that would be how stretchy the arterioles are. I mentioned that with age and calcification and arterial sclerosis, the compliance goes down. So you actually would feel a stronger heartbeat. And that's why if you palpate the radial artery in a lot of elderly patients, older patients, you'll feel a very strong heartbeat. You're like, wow, that's really strong. And that's partly because the arteries have all become calcified to some degree. And so we're seeing a much stronger pressure wave come through. So those are the three determinants there of pulse pressure. I mentioned the mean arterial pressure is the difference really between the systolic and diastolic pressures. And since we spend a little bit more time in diastole, it's not exactly the average, but this is the average pressure driving the blood into the tissues. So that's what all the tissues will experience. And this needs to have a certain amount of pressure, otherwise you will lack perfusion in those organs. So organ perfusion really depends on having healthy blood pressure. So organs like the brain and so forth would not get adequate blood and nutrition if we didn't have a certain amount of pressure in that arterial system. And of course, we use an instrument called the sphygmomanometer. blood pressure meter to do that. So you put the typical method there is to put the cuff on the upper arm and compress it, and you put a stethoscope, of course, underneath here, and you're actually listening to the blood flow through the brachial artery. And you inflate the cuff until you can no longer hear any sounds coming through. And that means all the blood has been occluded in the brachial artery, and that's going to be your upper limit. That's your systolic number. You let the pressure off the cuff, you listen. You can start hearing the arterial sloshing, as the blood comes through that narrow vessel. As it's still somewhat constricted, it'll make a sound. But then you'll get to a point where the artery is completely open again, the pressure's off, and you won't hear the sound of blood flowing, and that's going to be your diastolic pressure. So that's how we record blood pressures. Those sounds are the Korsakoff sounds, and that's a very convenient way for doing that. I'll talk all about what, again, normal blood pressure values are, the fact that we really need at least 3 readings at separate intervals to diagnose high blood pressure in a person, but that would be the basic technique. I just put this picture in here to illustrate some of the major arteries in the body, which you should be familiar with. So coming from the heart, we have the aorta, which has an ascending branch, and then it curves around, and then it's descending, and then it goes down behind the heart through the diaphragm, becomes the abdominal aorta. And then all these little branches are coming off it. So we have the celiac trunk, we have the arteries feeding the kidneys, they're called the renal arteries. Then we have a gonadal artery coming down, and then the aorta branches into what's called the common iliac artery on either side. And then we have those are going to branch further into, there's going to be a little external iliac artery coming down, and the internal, you see, comes down into the pelvic bowl here, and that's going to help give blood to many of the pelvic organs, bladder, and so forth. And then that's going to become, the common iliac artery will become the femoral arteries going down into the legs. And then the femoral arteries, as they go behind the knees here, will become the popliteal artery. And then we have a further branching into anterior posterior tibial arteries, and then down into the feet, where we have anastomoses and these little branches that come off of them, so the blood can get from either vessel, can get blood flow to the feet. So that's the arterial system. Going up into the head, we have a couple of branches coming off the aorta. So one starting on the patient's right side here is a so-called brachiocephalic trunk, and that off that trunk comes the vertebral artery and the common carotid artery, which divides into an internal and external carotid artery. This is, remember, the vertebral artery and the internal carotid artery will feed essentially the brain. That's the arterial supply to the brain. And then the brachiocephalic trunk here will become the axillary artery. Down becomes the brachial artery, and then down in the arm, it actually splits into the radial artery following the radius, and the ulnar artery following the ulna. So, and then we have again another anastomosis down here with what are called digital arteries going down into your fingers. A little bit different on the patient's left side here, where we don't have the same brachiocephalic trunk. Instead, coming off the aortic arch, we have the subclavian artery, and then the carotids and so forth come off of that, and that's what's going to become on the right side the axillary artery and the brachial artery and so forth. So that's kind of the arterial system in the nutshell. I might advise that you get a good, even something like an anatomy coloring book, and actually go through and color all those. That can help that, maybe impress that into your memory a little bit more. But these will be the major arteries we need to know about. Arterioles have 2 major roles. So remember, these are the smaller branches off the arteries. They're going to help determine, based on the ability to vasodilate and constrict, the relative blood flow into individual organs at any given mean arterial pressure. So we have the mean arterial pressure pushing the blood, but we also have this vasoconstriction, vasodilation element for further regulation. And this, of course, this mean arterial pressure with that ability to regulate the blood flow is going to help determine what actually gets into the microcirculation. Remember I mentioned there are a number of vasoconstrictors and vasodilators, the sympathetic nervous system being a major one. So here's the typical kind of schematic of blood flow coming from the arteries, going down into the arterioles. And then as we'll see, there's going to be a little smooth muscle sphincter here. It's called the precapillary sphincter, and that will actually help regulate how much blood gets into the capillary beds. That's going to feed whatever tissue this is a part of, and then bring waste products back, and then that'll all collect into the venous system, into the venules going back to the veins. Now, one system is not shown here, which will be important, and again, I'll look at this with the microcirculation, is when the mean arterial pressure and the blood flow comes down into the capillary beds, the pressure actually pushes out a certain amount of plasma. And again, we'll look at the forces that either pull blood into the capillaries or push them out. I'll just say here they're known as the Starling forces, but we'll look at what those are here shortly. But let's say some of the fluid comes out and whatnot is pushed out. That's going to contain often, not a lot of protein, because most of the larger proteins stay in the blood itself. They're not permeable to the basement membrane and the capillaries. But if there's a lot of inflammation and so forth in these tissues, a lot of very high protein fluid builds up. And unfortunately, that protein, again, can't move across the capillary walls. So the question is, how do we get rid of that protein? Well, we have another system that stands right by here, and that is the lymphatic system. So the lymph, one of its major roles is to carry away high protein fluid from the tissue spaces. And we'll look at what can happen when this becomes blocked or this system is not efficient. We can actually get a swelling in the tissues of fluid known as edema. And there are different types of edema. I'll just say quickly here that there's one type known as pitting edema, where if you press on, a person's leg with edema, it can retain your thumbprint for, several seconds, versus non-pitting edema, which does not pit to your thumb and pressure. It turns out the non-pitting edema is usually due to a problem in the lymphatic system. So that would be from buildup of the high protein fluid in the tissues. The pitting edema will have other causes, but that usually is a collection of low protein fluid in the tissues. Okay, so the baseline activity of the vascular smooth muscle that sets the level of contraction of the arteriole is known as intrinsic or basal tone. And we have different controls on that tone. I've mentioned, I'll just start with the so-called extrinsic controls here first. I mentioned the sympathetic nervous system, so generally norepinephrine via alpha-1 receptors will be vasoconstrictive. So the higher the sympathetic tone, the more vasoconstriction. Parasympathetics, not really, very few fibers we think innervate these arterioles, so we don't really pay attention to that as much. There are different nerves known as non-cholinergic, non-adrenergic nerves, and they secrete neither norepinephrine nor acetylcholine, which is the main secretion of your parasympathetics, but instead release nitric oxide together with other vasodilators. And this is very common in the gut and in organs like the penis, which allows for vasodilation. When the increased blood flow collects in the penis, the veins that drain the blood constrict, and that increased blood flow causes an erection. Finally, different hormones can work on the arterioles. So epinephrine, again, works like norepinephrine. This is from the adrenal medulla. Unfortunately, again, in some tissues, it's a little more difficult because you have, for example, beta-2 receptors in your skeletal muscle, which when they're stimulated will cause vasodilation, as I talked about earlier. Angiotensin 2 is a peptide hormone I mentioned before, part of the renin-angiotensin-aldosterone system, which is a vasoconstrictor. So is your vasopressin from your posterior pituitary. And then another one, which is very interesting. We now know that the heart itself actually secretes hormones, peptide hormones. So it is an endocrine gland, like just about, well, really every organ. But the heart puts substances into the blood, and one of them is known as atrial natriuretic peptide. There's also a ventricular natriuretic peptide, and this actually goes by the name of BNP because it was first discovered in the brain. So we call it brain natriuretic peptide, but it's actually ventricular natriuretic peptide. Anyways, ANP is when it's released into the blood, and the typical reason for it to be released would be increased fluid volume stretches the chambers of the heart more. When they get stretched, they're going to release ANP into the blood. That travels in the blood to your kidneys, and then it causes the kidneys to diurese, to eliminate fluid volume. It also acts as a potent vasodilator in the periphery. So the heart can regulate blood pressure and diuresis. So it's a really beautiful example of how organs like the heart and the kidneys can actually communicate through the endocrine system here. So those would be extrinsic controls, factors working outside or more globally on the vasculature. But there are also local controls that are independent of the nerves or the hormones. They can alter arterial resistance. So something called active hyperemia, this would result from increased metabolic activity in the tissue. So as tissues like muscles need more oxygen, they have different things that they can initiate to actually get more blood flow into the tissues, and that creates more hyperemia or congestion of the blood. Flow autoregulation. This helps to maintain a constant flow through an organ despite changes in blood pressure. So that allows a constant perfusion pressure in the different tissues. Reactive hyperemia. This would be a profound temporary increase in blood through an organ that's had its blood supply temporarily occluded and then restored. So if you have, for example, an embolus that blocked blood flow, that embolus may be dissolved or was removed. There'll be a sudden increase of circulation in that tissue, and that can cause reactive hyperemia. And then any local response to injury, for example, inflammation, is going to typically cause vasodilation. So the very initial phase of inflammation, like after an injury, is vasoconstriction. And then within less than an hour or so, we're going to see actually the blood vessels dilate. And that's going to allow immune cells and nutrients to flood into those tissues to initiate the healing process. So those are some of the factors, local and extrinsic, on blood vessels to regulate the circulatory flow. I wanted to create a whole slide here about endothelium because they're so important for overall cardiovascular health and homeostasis. These are the cells, again, they're a special type of epithelium that line blood vessels, and they're also what compose lymph vessels, the lymphatic vessels. Embryologically, they all originate from the mesoderm. In fact, in embryologic development, the cells that, the precursor cells to all your blood vessels, the endoderm, the endothelium, I'm sorry, as well as your red cells and all your blood cells actually all come from the same precursor cell. So all the blood elements have the same embryologic precursor. And what happens is as they start flowing around the embryo, some of them deposit out along the edges of that circulatory stream. So imagine a whole bunch of cells just flowing here in a certain direction. Some of them start to precipitate out along the stream, and those are going to form your blood vessels. They actually differentiate into the endothelium, whereas others that stay in the blood will settle down in organs like the bone marrow and whatnot, and they'll start to form your blood. So both the inner lining of blood vessels and your blood cells come from the same embryonic origin. And that's why when you look at organs like the heart, it's very interesting to look at this, to examine this idea that the chambers of the heart were actually laid down by they really were, if you look at the heart muscle, it actually has a spiral configuration in it. And it's almost like the cells that were in the fluid flow just sort of deposited along the outsides of that fluid flow. And that's what created the chambers of the heart. That'll become more clear when I look at heart embryology specifically in the coming videos. So again, if we look at vascular endothelium, this lies in direct contact with the blood. Again, it lines the entire circulatory system from the heart to capillaries. And in the heart, the endothelium is given a special name. We call it the endocardium. So the very innermost layer of the heart, the endocardium, is made up of endothelium. The vascular endothelium helps to regulate cardiovascular homeostasis, and I'll show you how that happens here shortly. And it also helps to regulate vascular tone and regulates oxidative stress, free radical damage, and so forth. Lymphatic endothelium is in direct contact with lymph, so a little different. So the basic functions of endothelium, it has a barrier function, so it's going to determine what leaves the vessel. It acts as a filtration barrier, like in the kidneys. Kidneys, really the functional unit of the kidney, the nephron. At the very beginning of the nephron, there's a little clump of capillaries, and basically the blood going through that is going to be the plasma is going to be squeezed out, going to be filtered through the endothelium in the basement membrane there. And it's going to collect in a little capsule, then it's going to go down a little tube, and it's going to be reabsorbed, most of it, as it passes down that tube. We'll look at that when we come to kidney physiology. But that function is regulated by the capillaries. They can control blood pressure via vasoconstriction, vasodilation. Now, endothelium does not have smooth muscle in it. So again, it's just a cell. It does have some muscle filament proteins, so it can relax or constrict. So this is different than what I'm talking about with smooth muscle in the tunica media of our arteries and arterioles. Endothelium participates in inflammation, so it can actively signal immune cells, so it can send out cytokines and whatnot. Normally, endothelium prevents blood from clotting inside your blood vessels, so it inactivates the coagulation cascade. And it does so by secreting various factors, and I'll look at one down here shortly. Endothelium participates in the formation of new blood vessels. That's known as angiogenesis or angioneogenesis, neo meaning new vessels. And that can be very important, obviously, for any tissue that became damaged or injured, capillaries were broken in there. You can have little sprouts that actually sprout off the capillary beds and regrow into that tissue. Unfortunately, tumors also can secrete factors that actually attract in blood vessels, and thereby they can hijack your own circulatory system. And there are a couple of drugs on the market that actually work as anti-cancer agents to block that. They're actually inhibitors of angiogenesis to prevent that from happening. The capillaries are where the neutrophils will actually adhere to that are floating around in the bloodstream. They will attach themselves to the endothelium. Then that will help them migrate, undergo their so-called diapedesis. They'll squeeze actually between endothelial cells, and they'll go into the different tissues. And they're involved also in hormone trafficking and regulation of hormones. They can actually metabolize different hormones and so forth. That's the basic roles of capillaries. Again, just a minute here, I'll look at the fact that there's three basic types. But basically, we can go from what's called a continuous capillary, which is not very leaky. The endothelium is very tightly joined together, and the basement membrane is very thick. So we find this, for example, in the brain. So remember, the blood-brain barrier is formed by continuous capillaries, and they get further wrapped in astrocytes, which come around and they form a wrapping around the capillary. And that's what's going to prevent substances from the blood from moving into the brain without being actively transported. Fenestrated capillaries have little holes in the endothelium, and that allows more substances to come in and out. This happens in the kidneys, for example. And then sinusoidal capillaries, we find this in the liver, for instance, are very leaky. So notice the huge clefts between the capillaries. And this is basically all the blood that comes in from the portal vein from your digestive tract that's absorbed all the glucose and nutrients will go through the liver, and these large gaps will allow all those nutrients to leak out, basically. And then the liver cells will take them up and metabolize the glucose and the fatty acids and amino acids and whatnot. So that's the three types of capillaries: continuous, fenestrated, and sinusoidal. But various factors are released by endothelium. So basically, we can think of them as vasoconstrictors and vasodilators. So they're going to work on the smooth muscle underneath the endothelium in arteries and arterioles, and that will regulate the vasoconstriction and dilation. So I mentioned nitric oxide previously. It's also known as endothelium-derived relaxing factor. Again, inducible nitric oxide, ENOS, is the enzyme that's going to convert L-arginine and arginine and take off a nitric oxide group as needed. So this is going to essentially promote, it's going to diffuse into the smooth muscle layer, and that's going to promote vasodilation. Both inflammatory substances like bradykinin and histamine are present in inflammatory states, and they're actually going to increase the level of nitric oxide levels, and that's going to allow blood vessels to dilate going into an inflamed area of tissue, and that will bring more blood flow, and that will cause more hyperemia in that local tissue area. Another important secretion by endothelium is a icosanoid called prostacyclin. This is in the prostaglandin class. This is secreted usually in inflammatory states. So in the basal state, we only secrete a little bit of it. But this is actually made from fatty acids in the walls of the endothelium. There are enzymes there that can cleave off the fatty acids and they can make prostacyclin from it. And the prostacyclin causes both vasodilation, but primarily it inhibits platelet aggregation. So it's going to prevent the blood from clotting within the vessel. So that's how the endothelium will protect that. Now, interestingly, we'll look at this later, but platelets actually can create another icosanoid called thromboxane. It's abbreviated TXA2. And that actually does the opposite. Thromboxane actually increases platelet aggregation. So when thromboxane is activated, platelets stick together. So there's a constant balance between thromboxane and prostacyclin, almost like a teeter-totter. If you have too much thromboxane, less prostacyclin, it's going to be pro-clotting versus less thromboxane, more prostacyclin, you're going to be more anti-clotting. Now, interestingly, platelets don't have nuclei, so they can't make the enzymes that make thromboxane. However, they're given a certain level of those enzymes when they are created in the bone marrow. And when the platelets die, then they live for about a week. When the platelets go to die, then new platelets are made and you have new thromboxane. The prostacyclin can be made continuously by the endothelium because they have nuclei, they have all the enzymes to do that. So curiously, if you take aspirin, and you probably hear a lot about people taking aspirin to prevent blood clotting, one of the ways it's really working is that aspirin inhibits the enzymes that make both prostacyclin and thromboxane. But if you give aspirin over time, because the platelets, it takes the body longer to actually remanufacture those platelets and get those new enzymes to make more thromboxane, versus in the endothelium, they can constantly remake those enzymes. So aspirin is going to block those enzymes. It actually permanently, competitively, it covalently binds to the enzyme and inactivates it. So once aspirin binds to that enzyme, it can't be reused. But if the cell makes more of the enzymes, then it can be reused. You just get new enzymes. So basically, in the endothelium, they're constantly remaking prostacyclin versus platelets can't remake their thromboxane. So the teeter-totter swings in favor of prostacyclin. And as a result, there's going to be less clotting in the blood. So this is how we think aspirin prevents blood from clotting. It's really inhibiting the thromboxane on platelets. Over time, it doesn't have as much of an effect on prostacyclin on the endothelium, so the prostacyclin gets the upper hand. Now, we'll look at the recommendations currently for aspirin. It's actually not as commonly recommended anymore because, unfortunately, aspirin, by blocking the same kinds of enzymes in the digestive tract, results in a decrease of the mucus barrier in your stomach, and that predisposes you to stomach ulcers and gastritis, inflammation of the stomach lining. So the risks kind of outweigh the benefits at this point. So nitric oxide, prostacyclin are two vasodilators secreted by endothelium. There is a vasoconstrictor, and that's called endothelin-1, and that can be released in certain mechanical or chemical stress, and that causes vasoconstriction. So that would be when you first have an injury, for example, the endothelium releases endothelin-1, and that's going to cause the blood vessel to constrict to prevent further bleeding there. If endothelin-1 is overexpressed, then we're going to have vasoconstriction. That's probably going to also increase platelet aggregation, so it's going to kind of work like thromboxane. Both endothelin-1 and thromboxane are associated with increased coronary, different heart diseases, as we'll see. The clinical significance of endothelium is that we can have a pathological state known as endothelial dysfunction, which I'll discuss. And this is a hallmark for a lot of different cardiovascular disease, especially what we call atherosclerotic cardiovascular disease, ASCVD. We'll look in detail at what that is, but we think one of the pieces of the pie in terms of pathophysiology of ASCVD is endothelial dysfunction. There is a pattern in traditional medicine, such as Chinese medicine, known as blood stasis. And effectively look at blood stasis. That is where two things happen. One, there's an increased tendency to thrombosis. And number two, there is endothelial dysfunction. So we can say this is actually a part of the pattern of blood stasis. And what's very interesting is many of the herbs that have been traditionally recommended for blood stasis patterns in Chinese medicine and even in Western medicine, there's a similar blood stasis pattern that's often used in herbal circles. Those herbs have now been researched, and we're finding that they actually increase production of nitric oxide, they increase production of prostacyclin, and they downregulate production of thromboxane and endothelin. So the net benefit would be to increase circulation to tissues as well as prevent platelet aggregation. So the capillaries are the smallest blood vessels. They supply blood directly to the tissues, maintain tissue perfusion. And this is really where the exchange of water, oxygen, carbon dioxide, nutrients, and waste between the blood and surrounding tissues occurs. About 5% of the total blood volume is in capillaries at any given time. And there are about 25,000 miles of capillaries in an adult. So 60,000 miles total blood vessels. A good chunk of that is the capillaries. The average inner diameter is only 5 to 10 microns, which is just wide enough for a single erythrocyte to squeeze through. By comparison, the average human hair is about 100 microns, 10 times the size of the average capillary. Microcirculation describes the flow of blood through the capillaries. So if we look at the anatomy and function, the blood enters the capillaries via arterioles and leaves via venules. And if we look at the actual capillary, there are two types of vessels. They're what are called true capillaries and meta-arterioles. So here in the picture, we see a meta-arteriole down the middle. And that's going to provide a constant flow between the arteriole on this side and the venule on this side. And then branching off of that are the true capillaries, which are going to the erythrocytes, the plasma is going to go through here. It's going to basically diffuse nutrients into that tissue. There are little smooth muscles that are part of the meta-arteriole, and they're called precapillary sphincters. So you can kind of see them pictured here. And they're going to regulate the blood flow into the capillaries. So this is a further little control on how blood can flow into the tissues. It's pretty remarkable. So here we see the sphincters relaxed in this picture to the right. And all the blood is going through the capillary beds, versus here the sphincters are constricted. And so basically the blood just passes through that meta-arteriole. They're calling it the thoroughfare channel, and it's going to prevent blood from going to the capillary bed. So this is how the circulatory system can hold back or give nutrients to different tissues. The blood flow through the capillary beds is not continuous. There's actually an intermittent little pulsating flow. It's called vasomotion. And that's regulated by chemical triggers that are occurring in the tissues that capillary bed is embedded in. So for example, if the tissues start to accumulate more carbon dioxide, the little contractions actually increase, pumping more of the circulation into that little tissue bed. Same thing with lactic acid and so forth. So that's actually a very important factor that is going to drive not just blood into the tissues, but also the blood's going to be coming out into the venule. So it's really what's going to drive blood. The relative metabolic activity in the tissue is going to determine how much blood will actually enter the venous system and go back to the heart. And we'll see later that one of the primary drivers of the heart and the output of the heart is actually not the contraction of the heart muscle, it's how much venous blood comes back to it. It's called the venous return. And so venous return is highly determined by the metabolic state of your tissues. I mentioned that angiogenesis is the growth and development of new blood vessels, and that's largely mediated by capillaries. So there are angiogenic factors, and a very important one is a factor that's actually secreted by endothelial cells called vascular endothelial growth factor. In this case, it's actually secreted by fibroblasts. Fibroblasts, remember, are connective tissue cells. They move into an area to help repair it, but they release VEGF or VEGF, and that will stimulate endothelium to grow, to form little buds, and to form new capillary systems. I again mentioned that in cancer therapy, there's a class of angiogenesis inhibitors They block agents like VEGF to prevent that from forming a new circulatory system into a tumor. Okay, so that's a little bit there on capillaries. I mentioned earlier there are three basic types of capillaries, the continuous, fenestrated, and sinusoid, and they have different sort of ability of substances to penetrate through them. Continuous capillaries are found in nearly all tissues. They have a complete endothelial lining and a very strong tight junctions between the cells. The tight junctions are loose in capillaries, and they can actually form intercellular clefts. So even in continuous capillaries, there's some degree of loosening between the tight junctions. And those clefts allow for exchange of water and small molecules between the plasma and the fluid in the tissues called interstitial fluid. So things like glucose, water, small hydrophobic molecules like gases and hormones, white blood cells can pass through those intercellular clefts. Many of the continuous capillaries, the endothelium, also have transport vesicles, and they can actually transport via endocytosis and exocytosis different substances. In the brain, I mentioned the basement membrane around the continuous capillaries is the thickest, and there's also astrocyte extensions, those end feet that wrap around the capillaries, and that's going to help form the blood-brain barrier. Also, importantly, in the brain, there are no intracellular clefts, so that's going to give an additional barrier there. Fenestrated capillaries have pores called fenestrations, in addition to the tight junctions in the endothelial lining, and that makes the capillary permeable to larger molecules. So we see that very commonly in the small intestine, in the kidneys. That's part of the filtration barrier in the kidneys. So large molecules can all pass through those fenestrations without having to be actively transported. We also see that in different endocrine organs and in a place called the choroid plexus in the brain. Remember that basically that's where the cerebral spinal fluid is manufactured. So in the pituitary, pineal gland, thyroid, etc., these have fenestrated capillaries. And remember, some of these areas in the brain are actually where there's no blood-brain barrier. So again, the fenestrated capillaries are not as protective, not as filtering as the continuous capillaries. And then the least common type would be the discontinuous or sinusoid, and they have very sort of flattened and very wide intracellular gaps and very incomplete basement membranes. They have a lot of intracellular clefts and fenestrations. They kind of look like Swiss cheese, and that's going to allow the passage of all sorts of large plasma proteins in different cells. It also slows the blood flow through those areas, and that actually allows the exchange of more of the nutrients between the tissues and the capillaries. So this is very common in the liver, also in the spleen, where red cells go through and they actually break apart. The old ones break apart and then they are recycled. And then bone marrow, lymph nodes, different endocrine glands like the adrenals and the pituitary will also have sinusoidal capillaries. So these are just some of the different types of capillaries, where they're found and their different functions. Now, there are three basic ways in which substances can move between the plasma and the interstitial fluid in the capillaries. One is by simple diffusion. So this would be basically just crossing the endothelium and basement membrane from the blood to get into the tissues. So lipid-soluble substances like gases like oxygen, CO2, they diffuse really easily. Polar molecules and ions are very poorly soluble, so they got to pass through either water-filled channels in the endothelial lining or special active transporters. And then protein, except for the capillary beds in the liver, is mostly kept inside the capillary lumen and does not diffuse out. So proteins like albumin should always stay inside of the capillary bed, inside the circulatory system. And in just a second, I'll explain the importance of that. A second way that substances can move between plasma and the interstitial fluid would be vesicle transport. So this would be via endocytosis or exocytosis. This would be for larger nutrients. And then finally, what's called bulk flow. And this is a movement of a fluid from a region of higher pressure to a region of lower pressure. And this is the mechanism that actually distributes protein-free plasma into the extracellular spaces. This is really a way to distribute water, not so much nutrients. So in the average person, of 70-pound-kilogram person, this would be the average person here has about 11 liters of interstitial fluid and 3 liters of plasma in terms of actual fluid. So one method of bulk flow is filtration, and that's a movement of a protein-free plasma from the capillary to the interstitial fluid. Absorption would be movement of fluid from the interstitial space into the capillary. So there's got to be a certain amount of filtration versus absorption, and that has to be kept in balance. The concentration of all plasma solutes except protein are virtually the same in the filtering fluid as in the plasma itself. So basically the nutrients just move with the bulk flow. So again, this would be a way of distributing those nutrients, basically by distributing the water. Now, there are forces that move that protein-free plasma out of capillaries into the interstitial fluid, and forces that move it back into the plasma. And their net balance determines what's called the net filtration pressure, how much goes in versus how much goes out of the capillary. And that's going to determine the direction the fluid will actually flow. And these are known as the Starling forces, named after the physiologist who worked this out. So the Starling forces determine the fluid movement through capillary membranes. And there's 4 of them, 4 basic ones. It's very easy. Basically, there's one force called the capillary hydrostatic pressure, and that's just the pressure inside of the capillary, which is going to push the plasma out in the interstitial space. So anytime you have a hose with pressure, if there's some leakiness, it's going to come out into the space around it. That's the capillary hydrostatic pressure. We abbreviate that PC. There's also the interstitial hydrostatic pressure, and that's the pressure in the interstitial space. We're going to push things back into the capillary. So that's another force, and that's abbreviated here PI. Then we have the plasma protein oncotic pressure, and that would be primarily determined by albumin. So mostly we have a lot of albumin inside the vessel. It's impermeable, it can't come out through the capillary. And then we have a little bit of albumin out here, but not as much. But because there's a greater concentration of albumin inside the vessel, less outside, there's going to be an arrow that's going to force is going to be it's going to pull fluid back into the vessel. And that is the plasma protein oncotic pressure. So that pulls fluid into the capillary. Then there is the interstitial oncotic pressure. There are other proteins out here that are in less concentration in the blood, and they're going to exert an oncotic pressure, and they're going to pull fluid out of the capillary. So there's really 4 forces at work here, and we abbreviate them PC, PI, pi, P, and pi I. And basically the net fluid flow, JV, would be a coefficient here. Basically, we just subtract the capillary hydrostatic pressure minus the interstitial hydrostatic pressure, and there's another little variable here, and then we subtract the oncotic pressures. If we kind of look at actual physiologic situations, basically the hydrostatic pressure in the capillary and the osmotic pressure, oncotic pressure here, would be the 2 most significant. So the interstitial hydrostatic pressure really is pretty insignificant, and the interstitial oncotic pressure is pretty insignificant. So it's the PC and the pi P which play the most role here. We never calculate any of this clinically, but this is going to give us an idea of how to look at edema and understand how that works. So if we look at edema, basically that is excess fluid outflow into the interstitium. And it can be caused by 4 different factors. So increased capillary pressure, and that can happen, for example, in heart failure. So in heart failure, all the blood backs up in the venous system. That puts pressure on all the veins, so the pressure inside the venous system increases. And so that's going to increase the pressure inside all the capillaries. And so blood will more readily move from the capillary spaces outwards. So we'll have more fluid collecting out here, we'll get edema. So that's one cause. Another would be a decrease in the plasma protein. So if you have liver failure and your liver doesn't make enough albumin, well, then this arrow, the osmotic pressure, is going to decrease, right? So more fluid is going to stay out here instead of moving into your blood vessels. Can also happen in kidney failure. You can also have increased capillary permeability, so different toxins, infections, and burns can also cause more leakiness across the capillary membrane. And then you can have an increased fluid colloid osmotic pressure. So this would be, remember I mentioned the lymphatic system should be taking away most of your proteins that are collecting in the interstitial spaces. Those proteins that can't get back into the capillary system are filtered out by the lymph. Well, if you have lymphatic blockage, now we have a backup of all those proteins here in the space, and that's going to increase the osmotic pressure, pulling fluid out of the capillary system into the tissues. So those would be the four basic reasons for why we get edema, and then clinically we have to think through, okay, which one of those is actually occurring. And we'll talk later about how to work up edema. Again, we can differentiate pitting edema, which is basically buildup of low protein fluid out here. So it's not due to high proteins out here versus, pitting edema is low protein. Non-pitting edema would be buildup of high protein fluid out here. And so we can immediately, just based on if it's pitting or non-pitting, tell which of those situations is occurring. Okay, so that's a little bit on the Starling forces and the forces that maintain the net filtration pressure across the capillary beds. Finally, we come to the veins. These are the vessels that return blood from the capillary beds back to the heart. They have really three basic functions. So one, they act as low resistance conduits to allow the blood to get back to the heart. They help to maintain peripheral venous pressure, and that's going to help to actually maintain what's called the venous return, how much blood gets back to the heart, and that will determine how much blood the heart can actually pump out. And so we'll look at that factor. I mentioned that the metabolism in the capillary beds or in the tissues around the capillaries have a lot to say about how much fluid actually flows back into the circulatory system and goes back through the venous system to the heart. And then finally, their reservoirs, the veins act as blood reservoirs. About 64%, about around 2/3 of your blood at rest is actually found in the veins and the venules. So a very large reservoir for the blood. Now, again, the veins have the three basic layers. We talked about the tunica intima, media, adventitia that we saw in arteries, but they have a lot less smooth muscle than arteries. They have the valves, and those are the one-way valves that prevent backflow of blood in the venous system. And then the venules, which are immediately adjacent to the capillary beds, the small veins, are very porous, and they're going to allow some of the macromolecules to flow from the interstitium into the plasma. Again, only to a certain limit. Very large proteins will have to be filtered out by the lymphatic system. There's different types of veins, so what we call anastomotic veins. They're paired veins. They travel with medium to small size muscular arteries, and they form like a ladder-like rung between the paired veins. So if you have an artery here and a vein here going this way, we get these little connections, the anastomoses between them, and that allows for greater distribution of blood. In fact, one interesting finding is that of all mammals, humans have the greatest number of anastomoses, so the greatest ability, interestingly, to regulate the circulatory flow into different organs. Superficial veins are found in the subcutaneous layer under the skin. So when you see varicose veins in the legs, those are typically from superficial veins. We also have deep veins that usually are anastomose to the superficial veins, and they travel between the skeletal muscles. So in this picture, we can see some of the veins. Some of them are more towards the surface here, the superficial veins, and then we have the deeper veins that go in. So a lot of the varicose veins and whatnot are not involving the deep veins. We can get varicosities in the deep veins, and that's going to create more of a complications such as things like deep vein thrombosis. Now, there are several mechanisms that control the venous pressure, the pressure of blood in the veins. So one would be the fluid volume, obviously, in the vein, how much fluid is actually in the plasma. The compliance of the venous walls, so veins are very compliant. They can contain a large pool of blood, that's that blood reservoir function, and that will increase the venous pressure. So again, I mentioned that almost 2/3 of the total blood is present in the veins at any given time, but this is at really low pressure, about 10 millimeters of mercury. Whereas the arteries, again, contain about 15% of your blood, and they're at about 100 millimeters of mercury. So the veins are are a much lower pressure system. Sympathetic tone. So the veins are innervated actually by the sympathetic nervous system, which does have some effect at constricting the smooth muscle and veins, and that can regulate the venous pressure. And that would then increase the amount of blood flowing back to the heart, the so-called venous return. I mentioned the skeletal muscle pump earlier, and that's, for example, in your legs, skeletal muscles surrounding veins as you walk and move your legs will pump the blood back up through the vein, and the valves will prevent it from backflowing. And that's why it's important, like on long plane flights and whatnot, to get up periodically, stretch, but also walk, pump that, use those muscles to pump the venous blood back to the heart to prevent it from sitting there for too long. And there's different factors that we'll look at later that can lead to that blood in the vein actually forming a clot. And again, the danger there, in, for example, a deep vein thrombosis, is it can embolize back to the lungs, forming a pulmonary embolus. And then there's what's called the respiratory pump, and that's the when we take a breath in, that actually drives blood back to the heart. So that increases the venous return. So we can think of breathing as actually helping to pump the blood a little bit through the venous system back to moving it towards the heart. Okay, so that's the basic factors that maintain venous pressure and venous tone. Here's a picture of some of the major veins you should be familiar with. So here we already looked at the arterial system, but in terms of the venous system, our major vein collecting all the blood from the upper part of the body, including the subclavian veins, which come from the right and the left arm, and the jugular veins, which drain the head. All this comes down and collects into the superior vena cava, which drains into the right atrium. So that's part of the right side of the heart. The lower side of the body will all collect into the inferior vena cava, shown here. Now, notice that they drew some branches here. So this is the splenic vein, the spleen's over here. But all of the GI tract in here drains into the portal vein, which goes to the liver. And then all the blood, once it filters to the liver, will collect and then merge into the inferior vena cava as well. Going down further, we have the iliac veins, just like we had the iliac arteries, and there's an internal and external, and then we have the femoral vein, which collects up there. So this kind of just parallels the arteries. We have the popliteal vein down below, and then a posterior and anterior tibial veins, just like we saw with the arterial system. And similar kind of divisions that we have in the arm. So just be familiar a little bit with some of the venous system. Again, the nuance here would be, I think, the liver system with its own portal system collecting blood from intestines, all the blood, all the nutrients you absorb, with the exception of the large chain fatty acids, anything over 10 carbons long. That will actually go through the lymphatic system, and that actually collects up to the lymph system through your chest, drawn in green here, the so-called cisternic chyli, and then into what's called the thoracic duct, and that actually drains into the left subclavian vein right here, and that goes back to the heart. So fats actually go through that system and go to your heart first before they go through the liver. But amino acids, all your carbohydrates, everything goes to the liver first. It's processed by those hepatocytes, and then it's put into the inferior vena cava, and that goes back to the heart. So that's a little summary of the venous tree. Finally, I just want to say a few words about the lymphatic system. It's not technically part of the cardiovascular system, but it's comprised of lymphatic vessels, or lymphatics. They're small tubes of endothelium that convey lymph, and that's a fluid that's really derived from interstitial fluid. Usually has a lot more protein in it than plasma. The lymphatics actually have valves, just like veins, and the lymph enters the lymphatic vessels from lymphatic capillaries. So if you look at the microcirculation, here's a capillary bed. And I showed you before how the blood goes through the precapillary sphincters, through that meta-arteriole all the way across, and then the capillaries that branch off of it, collects into a venule, back into the veins. The lymph kind of reach in there and then they have their own capillary network, and that all is going to drain into the capillary system. So if we look at where the lymphatics actually re-enter circulation, it's going to be up there at that thoracic duct I pointed out. That is really where all of your lymphatics will rejoin up in the thoracic duct. It's not shown here, but again, that's going to be in your left upper chest area by your left subclavian, goes into the left subclavian vein. Any blockage of the lymphatic system will result in that high protein edema, and that's going to be resulting in a non-pitting type edema or swelling in the tissues. Fats are, again, absorbed into the lymphatic system, the larger fats, over 10 carbons long, and they'll bypass the liver, unlike the other nutrients. And another important thing to consider is many cancers, especially solid tumors, adenocarcinomas and whatnot, spread primarily through the lymphatic system, not through the blood. So they metastasize via the lymph. So looking at lymph nodes, tracing how cancer is spreading through them is a very important part of staging cancers. Our main staging system for cancers is the so-called TNM system, tumor nodes, lymph nodes, and a metastases system. So we get each tumor is given a certain number of those on those different parameters, and that helps us to stage the cancer. Lymph nodes are located along sort of in the pathway of these lymphatic vessels, and they're just basically collections of antigen presenting cells, T cells, B cells, plasma cells that are constantly filtering that lymph for any antigens and launching an immune response against them. Again, the spleen is interesting because it actually can be considered like a giant lymph node, but unlike the other lymph nodes connected to the lymphatic system, the spleen is directly in the pathway of the blood. So it's a giant lymph node for the blood. All right, so that's, I won't go into depth on the lymphatic system. You probably saw that in immunology already. So this should help you connect those ideas with this. So that's the summary for the anatomy of the cardiovascular system. In the next video, we'll look at the heart anatomy specifically, look at the different chambers, structure of the heart, the electrical conducting system, and then we'll launch into the physiology of both of these and see how blood pressure and all those things are regulated.